where we left like half the chapters that we didn't have to do, but all right. So third-party reimbursement issues. Each coding system plays a critical role in reimbursement. Your job is to optimize payment. So do you guys know what a third-party payer is? That is simply insurance. Your third-party payer is your insurance. So your question is, what entity is the largest third-party payer in the United States? It's Medicare.
Yeah.
So what is your responsibility as a coder? So, oh, y'all say hi to Miss April. She just popped in.
Hello.
Hi, good afternoon. How are you guys doing?
Good.
Good to see you guys on. Such valuable information. How's the first? Well, I know Jenny, you've recently began. Catherine, what is your last name?
Oh, no.
How long have you been in the program?
She started the same day as Jenny.
Okay, good. Awesome. How's it been the last couple of weeks?
It's going good so far.
Good. You guys are going to be fine. You're getting into the meat and potatoes of coding. So very exciting, very important information here. So yeah, sit back, put your seatbelt on. It's going to be all right.
Oh, now that I can see everybody, I forgot I was sharing my screen. Oh, here comes Miss Wanda. Okay, Miss April, you have to wait because this is my favorite thing every week. Hang on. Hi, Miss Wanda.
Hi, Miss Marsha.
Every week, Miss April, that just makes me smile and laugh. So, Miss Wanda, I already did my first slide, but that's okay. We'll get caught back up. All right, so we're going to continue on with our lecture. So we were talking about what is your responsibility as a coder? Well, you need to ensure accurate coding data, obtain correct reimbursement for services rendered. Upcoding or just maximizing is never appropriate. And we're going to talk a little bit more about what upcoding is. So what is the coder's rule? To accurately code the services and procedures rendered so that the office is properly reimbursed. So the main thing there is accurately, because if you code something inaccurately, what's going to happen? They're going to send it back to you and say, we're not paying this. And so you're going to have to redo it. So is that going to happen when you're coding? Absolutely. It's going to be human error at some point. You're going to make mistakes, but that's okay. You'll get a second chance and you always learn from those mistakes. So what is upcoding? So upcoding is actually coding a higher number or a higher code than what you actually did. And when we start coding, we're going to go into that in detail. So now we're going to get straight into Medicare. So if you have a pen and paper, you need to write this down because it's going to be on your NCCT and it will definitely be on your first exam. The Medicare program was established in 1965. So the basic structure of Medicare is we have Part A and Part B. Part A is hospital insurance. Part B is supplemental, non-hospital. And these are just quick things, guys. We're going to go into it in more detail in just a minute. So for Part B is supplemental. For example, that's your physician services and medical equipment. Part C we call Medicare Advantage, healthcare options, and they're added later and formally termed Medicare Plus Choice. And Part D is dental. No, it's drugs. And the reason I do that every time I say I introduce Part D, because I had a student, oh gosh, it's been years ago, that I asked her what Medicare Part D was, and she told me it was dental. I said, no, it's drugs. And I told her that forever I would say that. Okay, so who's covered? So it was originally established for people who were 65 and over, but later disabled and permanent renal disease, end stage, or transplant were added. The people who are covered by Medicare are called the beneficiaries. So individuals covered under Medicare are called beneficiaries. And remember, beneficiaries are who gets the benefit. I think we had that key term last module, didn't we? Okay, the funds to run Medicare are generated from payroll taxes paid by employers and employees. So our next question is, who collects and handles Medicare funds? The Social Security Administration collects and handles the funds, which flows through CMS to the MACs. So MAC is a Medicare administrative contractor. All right, so this kind of brings us a little bit back to Part A through D. So Part A is hospital. Part B is medical coverage. Remember, our physician's offices are durable medical equipment. Part C is our Medicare Advantage. And Part D is prescription coverage. If I'm going too fast, if you're taking notes, let me know and I'll slow down. Okay, so let's go back into it again with a little more detail. So Medicare Part A, hospitals report services for Part A by using their ICD-10-CM codes. That's our diagnosis codes. That's the big purple manual that we were just talking about. Because in the hospital, it's about how sick you are. So the more diagnoses you have, the higher the payment. Medicare Part A would cover the basics of a hospital stay. A way to look at it would be the no frills stay. They're not putting you up in a hotel to enjoy. Part A can also help pay for inpatient care in a Medicare certified skilled nursing facility if the patient's condition requires daily skilled nursing or rehabilitation services that can be provided only in this type of facility. So, do you guys have any questions about Medicare Part A? Okay, so let's move to B. Boy, there's a lot going on this slide, I know. Part B is not automatically provided to beneficiaries when they become eligible for Medicare. Medicare Part B, like Blue Cross, for example, is an insurance the individual purchases and pays monthly premiums on. So it's not free, they have to pay for it. Currently, Medicare Part B reimburses at a rate of 80%, and the patient is responsible for 20%. So let's look at our little picture here. Covered by Part B are doctor's visits, outpatient care, home health care, durable medical equipment, preventative care. What's not covered by Part B? Hospitals, skilled nursing, dental and vision, hospice care, and prescription drugs. So I like this because it kind of gave us a contrast of what's covered and then what's not covered. So coding for Medicare Part B services it's a 3-coding system used to report CPT codes, HCPCS codes, and ICD-10-CM. So we're going to be doing the HCPCS manual too, but that's a little bitty manual and you guys are going to have fun in that. It's easy, easy, easy. Okay, so let's test our knowledge. So what year was Medicare established?
1965.
Okay, that's right. Who collects and handles Medicare funds?
Social Security Administration.
That they actually collect, but remember CMS and the MACs, the medical administrative contractors handle that. But that's not a bad answer. There's just a little bit more to it. All right, so give me something that Medicare Part A pays for.
Hospital.
Hospital, okay. That's great, Miss Wanda. What about Part B?
Doctor appointments.
Doctor appointments, great. Part C, what do we call that? That's the Advantage plans. I'm trying to think of an easy way to put that. We'll get more into that. Your little flyer that I made you, it'll be on Tuesday. You'll be able to see more on Part C. And then what does Medicare Part D pay for?
Prescriptions.
There's Chase. Chase, you are late.
Yeah, I know. I'm at work.
I just texted him and said, are you coming to Zoom? So D pays for what?
Prescriptions.
Prescriptions.
Drugs.
Drugs. So, all right. So this is another thing that you need to write down. You're going to need to know it. So what does HIPAA stand for? Health Insurance Portability and Accountability Act. If you've ever worked at a medical facility, there's HIPAA training every year. It was established in 1996. And this is the only slide on HIPAA that I've put in. And I'm going to tell you why. Because your daily assignment tomorrow has lots of information about HIPAA. And also your discussion question that's not due until 9/11 has a lot of information about HIPAA. So we will be covering that more. We're going to cover it a million times. Just get used to it because it's that important. Okay, so what is the Federal Registry? Well, this is the official publication for all presidential documents, rules and regulations, proposed rules, and notices. Now, in your textbook, you have actually a link that you can actually go and look at the Federal Registry. I was going to pull it up, but it makes your eyeballs cross. So I decided we would just make it as simple as possible to understand. Each year, proposed changes to the various payment systems are published early. Several months pass so the interested parties can comment and make suggestions about the proposed changes. The final rules are published in the fall edition, and changes are implemented to the following calendar year. So Medicare fraud and abuse. Now, I want to talk a little bit about those two words. So when we hear abuse, and I know that I have said this on one of our 5-minute conversations that we have in the mornings when you open up your daily assignments, but we need to really wrap our mind around when we talk about abuse. We're not talking about somebody slugging you or the mental or emotional abuse that comes to mind at first. We're talking about administrative, talking about paperwork. We're talking about coding. So abuse, do you remember, is abuse intentional or unintentional?
Unintentional.
It's unintentional, which really doesn't feel right for us to say that, does it? Because if we're talking in a personal way, that is very intentional. But this situation with the paperwork, with the administrative part, it is unintentional. What is fraud? Intentional or unintentional?
Intentional.
Intentional. That's right. So if you're saying Miss Davis got this procedure done and that procedure done and that procedure done and she didn't, that's fraud. Medicare defines fraud as the intentional deception or misrepresentation that an individual knows to be false and does not believe to be true, and makes it knowing that the deception could result in some unauthorized benefit to himself, herself, or some other person. So I kind of talked about it in my own words before we read that, because that was quite a paragraph. So let's talk about what are some examples of fraud. So there's altering medical records, upcoding, phantom billing, double billing for same service, and etc. So I want to talk a little bit about phantom billing, sorry. Oh, I'm trying to think. It's been about 5 or 6 years ago. There was a big medical fraud case that came across. A guy actually rented a warehouse, stole Medicare information, and was billing for durable medical equipment to Medicare. So that was phantom billing. The patients really, there were no patients for this doctor. It wasn't a doctor. It was all fraud. So that's phantom billing. That was a huge, huge ordeal. I mean, he had this huge, what warehouse saying that he had it full of this equipment and it was completely empty. He had a desk and a computer and a phone. That was it. So needless to say, it did not go well for him. So let's talk about beneficiary signatures. Most Medicare patients sign a standing approval, which is kept on file in the medical office. This allows Medicare claims to be billed automatically, which makes it easy for an unscrupulous person to submit charges for services that were not provided. Coders must validate that the services were actually provided by consulting the medical record or the physician. We have a slogan as coders. By the time you get done hearing this through these next 4 modules, you're going to want to have it tattooed on your body somewhere. If it's not documented, it did not happen. As a coder, if you don't have a medical record, if you don't have a super bill, if you don't have an indication, Dr. Joe can't come in and say, hey, Jenny, I want you to bill this code with no medical records. If it's not documented, it didn't happen. You have to say, Dr. Joe, would love to do that for you, but I need medical records. I need a super bill. I need something on paper that tells me it's been done. Fraud can be billing for services not provided, misrepresenting a diagnosis, kickbacks, unbundling services, falsifying medical necessity, routine waiver of a copayment. All right, so I'm going to talk about a couple of these. Let's talk about medical necessity. What does that mean when you're coding? So if I have an infection in my toe, and that's what I'm going to the doctor for, should I be billing for something like coronary artery disease that gets paid more?
No.
Oh, no, you shouldn't. Okay, so if I got that. I'll twist it around, guys. Let me start that. That was an okay scenario, but I'm going to go further. So if I go to the doctor with an infected toe, but they're going to charge for a cardiology appointment, or I go to a cardiology appointment, I have it backwards. I'm sorry. I go to a cardiology appointment and the main diagnosis is my toe is infected. There is no way that we can make that medical necessity meet. Does that make sense? Doesn't, it doesn't make sense. So I'm not going to go to my cardiologist appointment and get a bunch of other things taken care of. It's going to be my heart. It's got to make sense. I'm going to go to the foot doctor about my foot, or my primary about my foot, but my cardiologist, my ophthalmologist can't do anything about my toe. So it's medical necessity. It has to make sense. It has to be necessary. You can't go in for a tonsillectomy and then also have plastic surgery at the same time. There's not medical necessity. Guys, I am just drawing a blank with medical necessity right now. So let me just stop talking about that one. So waiver of a copayment. That's what I keep thinking about. So when you have a patient that continually comes into the office and he's Dr. Joe's friend and he says, oh, I don't have to make my copayment because Dr. Joe's my friend. He said to write it off. Is that something that we can do?
No.
Can't do it. Okay, let's talk about the OIG, the Office of Inspector General. They develop and release a monthly work plan. They outline monitoring of the Medicare program, and the MACs monitor those identified in the plan. The Office of Inspector General, the OIG, is responsible for developing a work plan that outlines the ways in which the Medicare program is monitored to identify fraud. So the Office of Inspector General works very, very closely with insurance. I've only had to submit a letter to the Office of the Inspector General one time over a claim that an insurance refused to pay, and we won. They wound up paying it. And usually all you have to do is send a letter saying that if you don't pay this claim, we're going to go to the office of the inspector general, and they'll look at what's wrong with the claim, and either they'll pay it or they'll help you fix what's wrong. They don't want that office to get involved. Complaints of fraud can be submitted orally or in writing to the MACs or the OIG. Allegations made by anyone against anyone. Allegations are followed up by the MACs and or the OIG. Now, here we go. We're going to talk about abuse again. Abuse reviews involve checking the proprietary or medical necessity of services that are billed. These reviews generally occur after claims processing activity. Okay, we're going to stop and take a deep breath, and I'm going to take a sip of my drink because I am getting so tongue-tied. Chase, you read. I'm kidding.
I'm about to say, oh, come on.
Okay. Abuse generally involves impropriety, lack of medical necessity, or services reported. Review takes place after a claim is submitted and may go back to do historic review of claims. So that kind of is talking about red flags. Like if you have a couple of things that come back where it looks like that you have abused the situation, you will be investigated. All right. So let's talk about kickbacks. What are kickbacks? We've talked about the anti-kickback law, right?
Yes.
So kickbacks are a bribe or rebate for referring a patient for any service covered by Medicare. Any personal gain equals a kickback. It's a felony, and you can get a fine, jail, or both.
Mm-hmm. Like getting tickets to a ball game.
That's right. No saints for Dr. Joe. So let's talk about managed care organizations. They are responsible for healthcare services to an enrolled group of persons, coordinates various healthcare services, and negotiates with providers. These are insurances, are called managed care organizations. So what's a PPO? PPO providers agree to provide services to enrollees at a discounted rate. Enrollees pay a portion of the cost using a PPO provider. Out-of-pocket costs are greater when healthcare is obtained outside of the network. Patients have in-plan benefits and out-of-plan benefits. Don't y'all just love that? Isn't that cute?
What does PPO actually stand for? Like it's an abbreviation for what?
Oh my goodness. Hang on, Chase. Let me get it.
Think it's preferred provider organization.
Yeah, preferred provider organization. It was that
Thank
first
you.
word that I could not think of. Preferred provider organization. Thank you, Jenny.
You're welcome.
Y'all, I'm having an off day today. HMO. A health maintenance organization. There you go, Chase. HMO. Health maintenance organization is a healthcare delivery system that allows the enrollee access to all healthcare services. Each enrollee is assigned a primary gatekeeper who has the authority to allow the enrollee to access the services available or to authorize services outside of the HMO. HMO can employ the physician in a staff model HMO, or can contract the physician through the individual practice association model in which the physician provides services for a set fee. Yes, it's a lot of words. Yes, it doesn't, you can't kind of connect the dots yet, but we're just getting the information. We're just getting the words before we get the actions. So let's talk about drawbacks of managed care. The organization has incentive to keep patients within the organization. Services provided outside of the organization are limited, And patients must have approval to go outside the patients must have approval to go outside organization if the services are to be covered. Y'all send your instructions